What up, guys? Today we're going to be talking about thyroid storm. Is it myroid? Is it thyroid? Or is it thyroid storm? And a lot of this presentation, in fact, most of it is coming from a third-year medical student that wishes to remain anonymous. So thank you to them. All right, what are we going to talk about today? How do you diagnose thyroid storm? What are its features? Also, how is thyroid hormone metabolized? Once you diagnose thyroid storm, how are you going to treat it? The difference between P2 and methimazole specifically is very confusing to me, so I elucidated this in this talk. And also, what are the complications, mortality, and morbidity from this disease? Also, in emergency medicine, what are the common pitfalls and misdiagnoses, and how do we avoid them? What is thyroid storm? The first thing we're going to talk about. Thyroid storm is basically an exaggerated presentation of thyrotoxicosis. So thyrotoxicosis is a hypermetabolic state that comes from an excess of thyroid hormone. The most common thing to cause thyrotoxicosis is Graves' disease. Some features would be increased beta adrenergic activity like sweating, palpitations, hypertension, irritability, nervousness, tremor, and also hypermetabolism. So breaking down a lot of lipids, breaking down a lot of protein, increased metabolism, peeing a lot, dehydration, can all be signs. And if you, on top of that, have already misregulation of your thyroid hormone status and have a hypermetabolic state, on top of that, you get another kind of insult that increases the norepinephrine, epinephrine, and corticosteroid tone onto your body, then you're going to have thyroid storm. And thyroid storm can result in a ton of organ systems being affected. And you can think about this logically, because if you have hypermetabolism, you're going to have a ton of sugar suddenly leaking into your blood. You're going to have hypermetabolism in your liver, so your liver is going to get damaged. Your cardiovascular system is going to suffer because your heart's going to be pumping too hard. There's going to be fluid building up in the lungs. And also your brain is going to start frying itself, not only from the increased temperature around you, because you're going to become very febrile. You're going to start cooking your brain. Also, your neurons are firing on all cylinders. So that's another reason why you're going to cook your brain. This is just a slide from first aid. What I want you to pay attention to here is that peripheral conversion of T4 to T3, remember T3 is more active than T4, is inhibited by glucocorticoids, beta blockers, and PTU, which is what we give to patients in thyroid storm. Also, this is also from first aid. And this diagram is really good because it shows you how T3 and T4 is made from iodine and using thyroglobulin. Eventually, tyrosine is combined with iodine and thyroglobulin, and it all the way in the end right here creates T3 and T4, starting initially in the thyroid over here. And you guys can see that PTU and methimazole inhibit this process of creating thyroid hormone, but peripherally, which is more important to the acute symptoms of thyroid storm, PTU is mentioned here as an inhibitor of 5' deiodinase, which prevents T4 from converting into the more potent T3. And as you can see here from this last slide, this is also inhibited by glucocorticoids and beta blockers, specifically propranolol and also esmolol, as we'll talk about later. Okay, this is yet another slide that gives you a brief overview of what thyroid storm is. You can have different organ systems being affected, and those organ systems are going to result in the following symptoms. So agitation, delirium, fever, diarrhea, coma, tachyarrhythmia, all can be precipitated by acute stress like infection, trauma, surgery. And then tachyarrhythmia is the most common cause of death because if your heart's not working well, your cardiovascular system collapses and you die. Also increase in liver function test, as I mentioned, if your liver is working overdrive, you're going to have damage to your hepatocytes. And you can treat with the 4 Ps, so propranolol, propylthiouracyl, PTU, prednisone, a glucocorticoid, and potassium iodide, or lugol's iodine. Watch out for the Wolff-Chaikoff effect. So if you add iodide acutely, you're going to drop the T4 synthesis. So we take advantage of that when we get potassium iodide. What exactly precipitates it? Let's go into more details. You guys can read the slide for yourselves, but basically anything that causes stress on the body. So in the end, you have pregnancy. You have different medications that these don't really give stress on the body, but they specifically affect the iodine metabolism. So amiodarone is made of iodine, so it's going to affect iodine metabolism. Anesthetics, I'm not 100% sure how this works. And salicylates, specifically aspirin, are going to bring down your level of TGB or TBG, thyroid binding globulin. So if the level goes down, it's going to release that T3 and T4 that TBG is holding on to. Anything else over here important? Burns, strokes, traumatic brain injury. So anything that's a stress on the body, acute illness, trauma, thyroid surgery, specifically trauma to the actual thyroid, and abrupt discontinuation of the antithyroid medications can all do this. How are we going to know that it's thyroid storm? Basically, the biggest thing, if you get a patient with thyroid storm, most likely you're going to have them in your emergency room when they're still able to talk to you, or their family member at least brings them in if they're altered, and they can tell you that, oh, this patient's having diarrhea, they're having tachycardia, palpitations, they're very feverish, they're altered mental status. If you get any kind of these symptoms, and especially with a history of a thyroid issue like Graves' disease, you should be thinking of thyroid storm immediately on a differential, and your treatment should not wait. Also on your physical exam, you're going to be able to find goiter, orbitopathy, hand tremors, moist and warm skin, hyperreflexia, systolic hypertension, jaundice. Any of these signs should clue you into the fact that this patient has a thyroid disorder. How are we going to diagnose this? So there's a Burch and Wartofsky diagnostic criteria, BWDC, for thyroid storm. I like this one. There's a few other ones, but this is the one I'm going to talk a little bit more about. So it takes different factors that the thyroid gland can affect, and it gives you points for how severe these factors are in the presentation of the patient. So the first one is temperature. If the temperature is above 104, you get 30 points. Second one is your heart. So if you're tachycardic above 140, you get 25 points. Your central nervous system can be affected. So if you're in a coma versus extreme lethargy, psychosis, or delirium, you get 30 points versus 20 points, or just mild agitation gives you 10. If you have problems with your liver, so diarrhea, nausea, vomiting, abdominal pain, problems with your GI/hepatic function, you get 10 points. And if you have unexplained jaundice, you get 20 points, because jaundice is one of the terminal manifestations of thyroid storm. Congestive heart failure, if your heart is working overdrive and it can't compensate for the amount of blood it has to pump, you're going to start having blood building up. You're going to start to have heart failure, and your blood is going to start building up in your lungs, causing basilar rales or pulmonary edema in severe states. Or if it's just mild, you just have some swelling around the leg, so pedal edema. Also, you get a point for atrial fibrillation, because thyroid hormone, it makes your atrium more excitable and can induce foci, inducing arrhythmias like atrial fibrillation. So this obviously is not at the top of our differential in the emergency room, because it's a very rare disease. And I say obviously because it's very rare and unlikely to be encountered. So most likely people are going to be thinking, oh, this is sepsis, this is infection, this is psychosis, cocaine use, pheochromocytoma, neuroleptic malignant syndrome, hyperthermia, hypoglycemia, hypoxia, encephalitis, meningitis, hypertensive encephalopathy, withdrawal from alcohol, benzodiazepines, barbiturates, a heat stroke, or opioid withdrawal. So what's going to clue you into that this is thyroid storm specifically? It's a whole conglomerate of different symptoms coming together into one. So you can see individual parts of thyroid storm present in these individual differentials, but if they're all together, you have to be thinking about thyroid storm, especially in a patient with a history of Graves' disease or something similar. This is another grading system from Japan that you guys can look at that classifies thyroid storm. This is yet another one. And now let's get to management. So this is a more in-depth management screenshot. I believe the student took this from, I'm actually not sure what they got this from, but I break it down a little bit better further on. So quickly, you can see that the biggest thing is admitting to an ICU or getting the ICU consultants involved in this patient, because this patient is going to have continuous monitoring. You want to start to give drugs that inhibit thyroid hormone synthesis, so PTU, methimazole. You want to give iodine, like lugol solution, or saturated solution of potassium iodide, or lugol solution. You want to start giving IV fluids if their volume depleted, but obviously if they're in heart failure, you don't want to give IV fluids. And this next slide, this next thing, antipyretics or cooling blankets, very important. If they are febrile to above 104, you want to submerge them in an ice bath right away. because you're going to be saving their life. If they're above 104 and you're not cooling them actively, they have a very high risk of seizures and literally having their brain being fried. Because think about what happens if you put an egg into boiling water. You start to have the proteins coagulate. So that's literally what's happening in your brain. So you have to cool these patients very, very quickly. So don't just give Tylenol, and make sure you take a rectal temperature to check their actual core temperature. And if it's close to 104, or especially above 104, just start active cooling right away, and don't let them become febrile and hyperthermic to that extent. You want to give beta blockers, specifically propranolol, and esmolol can be given as well, especially in the ICU setting. You can give esmolol because it's fast on, fast off, and it's via drip. But if they can tolerate orally, you want to give them propranolol orally right away. And let's talk about methimazole versus PTU. So this is from first aid. These are just the basics. The way that I remember what you give in pregnancy, because it's a commonly tested fact, methimazole, you think of methimazole like meth. So you don't want to give it in the first trimester because it's teratogenic. Like meth, you think it's bad, so you don't want to expose the baby when they're developing to meth. So you want to give meth in the second and third trimesters, but you want to give PTU in the first trimester. So P for primary, PTU for first trimester. And let's see if there's anything else here. Yeah, PTU blocks the peripheral conversion, so P for peripheral as well. So this is 2 slides ago, what we just saw, but me regurgitating it in a more digestible format. So this is how you're going to start your treatment protocol as soon as Thyroid Storm enters in your top 3 of differential. I would say you would just start this treatment, and the worst that can happen is you give the treatment and it's not Thyroid Storm and they don't get better. So what you start with is you start with propranolol, for either 40 or 80 milligrams. You can give right away orally if they can tolerate it, or you can start esmolol drip, or you can give propranolol IV if they can't tolerate oral. You want to start with PTU. So PTU is better short term. In the first 24 hours, it actually drops the T3 concentrations much more than methimazole does, but methimazole is better long term. But for the first dose, you want to give PTU, also because it blocks the peripheral conversion. So that's probably one of the reasons why it's better. 1 hour after you administer these drugs, you give potassium iodide. And the reason you give this 1 hour after is because you want to give a thionamide, which is PTU or methimazole, because when you give potassium iodide, it can initially spike your T3 levels before the what is it called? The Wolff-Chaikoff effect. Let's see over here. Yeah, the Wolff-Chaikoff effect takes effect. So you want to give a thionamide, PTU or methimazole, before you give the potassium iodide, and you just give 5 drops on the tongue. And then you want to give hydrocortisone. You could actually give this simultaneously. I don't know why. In the show notes, it was written as 4th, but you can give hydrocortisone simultaneously, 100 milligrams IV, or dexamethasone 2 milligrams IV. You should also give cholestyramine, a bile acid sequestrant, to prevent liver damage from occurring. And you can give this one 4 grams. Also, make sure to remember external cooling. Do a rectal temperature, make sure they don't have a fever near or over 104 degrees Fahrenheit. And you can give acetaminophen for just a regular fever that's not exceeding 103 to 104. This is just another summary from Amboss of the things we just spoke about. Let's see if there's anything here that I missed. Something interesting, you can always give benzodiazepines for agitation. They're safe in an acute setting. You can consider plasmapheresis if the patient's not getting better after all your treatments. And let's see if there's anything else. And obviously external cooling is very important. It's in their top 4 here. Don't begin IV fluids unless you're sure that they're not fluid overload, because you don't want to worsen their heart failure. And watch out for tachyarrhythmia. So remember, tachyarrhythmias is what's going to kill your patient. So make sure they're on a monitor, and make sure you monitor their heart rate, and make sure they're not going to go into AFib or VFib or VTAC. That's going to cause them to throw a clot or any kind of complication from tachyarrhythmias. So We already talked about most of this, but prognosis and complications, arrhythmias is what's going to kill your patient. High output heart failure is also going to kill your patient, so watch out for that. Seizures, definitely give them benzos if you think that they're going to start seizing or if they're already having a seizure. Elevated liver enzymes and jaundice you're going to see later on. And abdominal cramps, vomiting, diarrhea, atrial fibrillation, thromboembolism can all be complications of this disease. Let's do a couple of practice questions. You guys can take a minute to read this, pause the video, and the answer is going to be hydrocortisone. And the next one, the answer is going to be PTU, propylthiouracyl. All right, thank you guys for watching, and I hope you learned something.